Bispecific antibodies have the appeal of being off the shelf and immediately available, but these are T-cell activating agents, and they have toxicities that are common across any agent that works with that mechanism of action, namely cytokine release syndrome and very, very rarely neurotoxicity. And so the challenge in the development of the bispecific antibodies has been how to avoid these toxicities coming on after dosing. And all of the agents that are currently moving forward have taken a step-up or split dosing approach, where the patient is exposed to very, very low doses compared to the target dose, and then there is intrapatient dose escalation to try to avoid cytokine release syndrome. Cytokine release syndrome appears to be related to the burden of disease in a patient, the amount of circulating disease in an individual, as well as the dose of the bispecific antibody. And so if you give a very low dose, then you can take the patient through that initial risk and then escalate the dose. And we know on second and subsequent dosing, the risk of cytokine release syndrome is much less. But managing and developing that step-up dosing has been a real challenge for all of us in developing these bispecific antibodies. The other preventative step that we take with one of them is to use obinutuzumab. That's unique to glofitamab. That's a way of trying to avoid cytokine release syndrome. But corticosteroids are also common across all of the bispecific antibodies. So the best dosing of corticosteroids is still an open question. We found in the glofitamab clinical trial that if we use dexamethasone as the preferred bispecific antibody prior to glofitamab, it actually reduced the rates of cytokine release syndrome, showing that there's a real relationship between these risk mitigating steps and the toxicity profile that we see. So I think these are challenges for all the development of all the bispecific antibodies. The other issue is the patient experience. So some bispecific antibodies are intravenous and, at least on the initial doses, have to be given slower, while epcoritamab stands out as a subcutaneous bispecific antibody. And theoretically, that should translate to shorter chair time, which is very important, particularly in socialised healthcare environments, and it's important for patients who don't want to turn up to hospital all the time. However, that needs to be offset by how frequently we ask patients to visit. In the case of epcoritamab, the initial step-up dosing lasts over several cycles, and there are frequent visits to the hospital that might offset the benefit in terms of time of that subcutaneous route. And I guess the other challenge for bispecific antibodies in the setting of aggressive lymphoma in particular is how long should we give them? We've seen two different approaches, one in the case of odronextamab and epcoritamab, where bispecifics are given indefinitely, and the other in the case of glofitamab, where bispecifics are given for a fixed term. And we don't know yet which approach is best. We don't know whether it's necessary to continue patients for longer, but we have seen in the case of fixed-term glofitamab, the intravenous bispecific antibody, that complete remissions are durable after that fixed term. So I guess a challenge for the field is what's the best approach and what's the best balance for patients in terms of the treatment experience, and of course, how should we best mitigate the cytokine release syndrome in particular.